So if you have a question, why don't you ask? May I use the opportunity to announce that we will have in February next year a Train the Food Trainer course in Central Europe. That's for us very important, supported by the IDF and also financially. So we have now a Train the Food Trainer course had in Brazil, in the Caribbean, and now we go to Central Europe. And also, you know, Stefan Morbach talked about the Pan-African Diabetic Food Symposium in Dar es Salaam in August. There are flyers on the table of future meetings. So if you're interested, please go, show your interest, and you can combine it with looking at elephants and other wild animals if you like it. So
I think, Carl, I think that if we raise some issues from these presentations, the key issue is better what experience we can take with us, not even outside the diabetic food area. Actually, when we want to change the pattern of something, or when we organize, we always discuss how much is patient-related, how much is organization, how much is lack of resources, and how much is related to our own traditions. So what I would ask you, Carl, by your experience, Stephen's experience, and Shiego's experience, is that there's one finding that I find interesting, for example, in Shiego's presentation, is that in Europe and in the Western countries, there are always a male dominance among diabetic foot ulcer. So, Shiego, please explain me, why are the Pacific region different?
This is a very difficult question because at first I was very much surprised to find that females are much more predominant than males. And we checked it again in another study to that whether it is true or not. But the fact female predominance is a true phenomenon in the Western Pacific region. And so we have asked many Asian doctors about, especially in the countries where females are much more predominant than males. And they express that females' life expectancy is much longer than males in these countries. And the another factor is that sometimes females work much harder than males as a farmers, and that they work on barefoot in their fields. And the WHO technical officers speculating that females' health problems tend to be neglected in some countries, and these factors will affect females' predominance. But further investigation should be necessary.
I would like to answer your question by comparing just the two talks that I gave. There are medical differences between the populations that you care for, between, let's say, Europe and developing countries like India and Africa. As I showed you, our major problem in Europe is peripheral arterial disease. So on optimized structure, easy access, right for a second opinion, right to have a vascular performance before amputation is what we need in the European countries, also proven by the results of the Eurodial study. And if you go in contrast to Africa, also to India, at least for the time being, there's mostly neuropathic ulcers. In some cases complicated by vascular disease, but most of the cases are still pure neuropathic and therefore in principle avoidable. That means in those cases, like we showed with the step-by-step project, it's important to have networks, to have places where people get a substitute for missing podiatry care, have nearby spaces where they can have their easy ulcers handled before they turn to septic gangrene, yeah? And therefore transforming, as I showed, the diabetic foot disease in those areas from a only surgical salvageable problem by amputation to a prevention disease. And there's another aspect important if you look to Europe, crisis, economic crisis, plus or minus, we still have health systems which cover most of the problems in most of the countries. This is not the case in any of the African or Indian countries. For those people, this is their own money that they spend on their foot disease, and they're losing their working time, they're losing the opportunity to earn money, and therefore the individual consequence of diabetic foot disease is a disaster, puts chaos not only on the individual but also on the family. Shigeo just spoke about the possibly not existing male dominance in most of the African, also the Southeast Asian countries like India. There's a male predominance, and mostly the people are at much younger ages than we have them in Europe. So if someone at the age of 40, 45 receives a major amputation, gets out of work, that means that a complete family is bankrupt. This is the different pictures that we can describe just comparing Western world and developing countries.
Professor William Jeffcoat.
Just going on from what Stefan was saying, one of the interesting things about comparing populations, I thought from the African data, was the very low prevalence of neuropathy at 10% in the population, which I thought was extraordinary. And I don't know if anybody's got anything to comment on that. But going on from the specific to the general, I really just wanted to comment that I think that the presentations we've heard this morning are actually a fantastic testament to what you have all done. The initiative of Step by Step and the work that you've done throughout the country has produced fantastic improvement, I think, from the evidence you've presented in the quality of health care. And it just shows what determination and vision can do, and you all need to be congratulated. But the side issue that comes from it, and anybody who might be trying to copy in a small way what you're doing, is the emphasis on information, on data, and that by working instead of as individuals, whether as a doctor or a nurse, but working as a team, and then a national team, and then collating all the information to give you evidence for the effectiveness of your work is really of outstanding usefulness. So really, my comment was really just to congratulate you all. Thank you.
Thanks. Thanks for the applause, and also thanks, William, for your comment. Two short responses. You are fully right that we have a wonderful tool with the step-by-step and also the train the foot trainer projects that we developed over the last decade. But what we're missing in many cases is the structured analysis of data that come out of the initiatives that we do. So at the moment we are finalizing it. For the last 2 years, in connection with the first foot trainer program that we did for the South American and Central American countries, we are now developing an online-based documentary tool that all those countries which are now implementing step-by-step centers in their region are obliged to use from mid of this year on to collect their data in an easy-to-analyze version, and by that getting much easier, much better access to the outcomes. And just one short comment to the first part of what you said, that you saw the astonishingly low numbers of neuropathy in the Egypt data. What we observed as well in India as in Tanzania in the early phase of studying patients together was also that there was a quite high number of obviously non-neuropathic diabetic foot patients. And I did a study with Dr. Abbas some years ago trying to find out if it might be an isolated small fiber or autonomic disease by doing an acetylcholine test in people who did not show signs of sensoric neuropathy. And it seems to be that either the small fiber disease, which cannot be detected by monofilaments or tuning fork, might be a reason, but also the special conditions there with very humid weather and tropic areas might lead to fungal infections or other diseases in short-term diabetes without obvious severe neuropathy leading to the same infectious complications as we say them in long-standing neuropathic people in the Western world. That's a possible explanation for this initial observation.
Carl?
We have to get to a close, but I like to compliment my, for your right-hand neighbor, my left-hand neighbor, and Belgium. Germany and Belgium really took the initiative to have a certified food clinic, and I think that's very important throughout the world. And I wonder if there are new initiatives on this or followers on this program. I'm amazed what Germany is doing, but also I think one of the items is not only dedication, but also that they get a kind of financial bonus for installing these certified food clinics. And I think, you know, that's little money, but the gain of the success and the reduction of suffering is tremendous if you have these outpatient clinics. So Belgium and Germany, congratulations. I think we have to get to a close now. We are hungry for coffee, I think. And so why don't we thank all the speakers in the chair for this interesting session. And we'd like to thank you for being here. And we are quite happy that we had a big audience. Thank you.